So I have a bachelor's in biological sciences. I have a master in public health and epidemiology, and I was a former medical student at the UConn School of Medicine. I've been with Central Connecticut Health District for the past 4 years. I started as a epidemiological intern and then transitioned into full staff. And I'm also an adjunct anatomy and physiology professor in the biomolecular sciences department in the Central Connecticut State University. So a little bit about us. So like I said, we represent the Central Connecticut Health District. And if you'd like to find out a little bit more information, you can scan that QR code and that will bring us to all of our pages, including our social media link pages. So in short, we are the local health department serving the 4 towns of Berlin, Newington, Rocky Hill, and Wethersfield. So we oversee about 100,000 people in our population. We are located in 2080 Silas Deane Highway in Rocky Hill, so right on the Silas Deane. And then there's our phone number and fax should you choose to go ahead and reach out to us. We could also be found on Facebook, Twitter, YouTube, LinkedIn. So we're a small agency, so we only have 12 people in our agency. We're divided in 3 branches. We have an administrative, a community health, and an environmental health branch. So Betty and I represent the community health branch. So we're led by Assistant Director of Health Ann Hartman, and each of us do a lot. So because we're such a small agency, we all have an extensive list of how many things we're responsible for. So, COVID has taken a lot of our responsibilities, as, most of you guys have been impacted as well. So to get into it, so we're one of Connecticut's local health departments. So there are 33 total municipal health departments, and that means that they just represent the town. And then there's 124 districts. So that can range anywhere from 1 to 20 district towns in one, and that's completely piled together. So this is how they're divided. The yellow ones are municipalities, the blue ones are combined districts, and we're just located as number 2, not really it's just numbered arbitrarily. So we're right at the center. So where do we get our power? So our guidance primarily comes on an international basis from the World Health Organization. And then on a federal basis, it comes from the Health and Human Services Department, or the Centers for Disease Control and Prevention, so the CDC. On a state level, we get our guidance from Connecticut DPH, or the Connecticut Department of Public Health. So we follow Connecticut statutes, we follow federal law. And then on a local level, which is what we represent, we also follow the municipalities' ordinances and statutes and regulations. So we have a lot of rules to follow and try to, squeeze our way and guide accordingly within those parameters. So that's public health in a nutshell. Prevent, promote, protect. We try to be proactive, but now we're in a reactive situation with the pandemic. So that's been the adventure. So I'd like to cover SARS-CoV-2, which is the actual virus name for COVID. So first, I'd like to touch upon briefly on what pandemics are. So pandemics are an infection that it's not just an outbreak or an epidemic, it's localized and regional. Pandemics cover multiple countries, and that's what we're at. We're at a global pandemic. So if you think back all the way back to high school biology, and this is the stuff that I'll gloss over very quickly, life is divided between prokaryotes and eukaryotes, and the only thing that I'll bring your attention to is one has a nucleus and one doesn't. And that's important because our virus that we're contending with right now uses that to its advantage. So also remind you of the central dogma, where DNA gets transcribed into RNA and then translated into protein. And the reason why I remind you guys of this is just, this is the method that we use in order to protect ourselves against the virus. So this is how we develop vaccines, and this is the current vaccine that we have. So in short, life can be divided into multiple domains, whether it be bacteria, eukaryotes, that's where humans lie. We're part of the vertebrates and animals. And if you take a look historically, eukaryotes suffer from RNA viruses, which is what coronavirus is, while prokaryotes, which are bacteria and archaea, usually suffer from DNA viruses. So we do have some DNA infections, such as herpes, such as chickenpox, but most of our problems come from RNA viruses. So this isn't anything new for us. However, it's been very, very impactful. So again, 99% of DNA viruses affect prokaryotes, and 65 to 75% of RNA viruses affect us eukaryotes. So the reason why most pandemics occur is as a form of population check. So as a thriving species, grows and it comes into contact with other stable populations. So all of these are stable populations. Aedes aegypti is just a mosquito. These are just random examples. E. coli. This is a common mouse. So as the thriving species comes into contact with stable populations, it gives the opportunity for a virus that maybe is stable within the animal population to jump onto the thriving population. So in this case, it's a zoonotic infection. So coronavirus came from bats. It was able to change in a way that it can also affect humans, and that's what we're contending with. And the way that that happens is as a form to basically bring back that thriving species back to a manageable population. So pandemics can be found in many animal species, from all different types of animals, from mammals to plant to wildlife. And then we've contended with multiple pandemics in our history as well, from polio to HIV, smallpox, influenza, Zika, Ebola, and now SARS-CoV-2. So, we're used to dealing with large, widespread pandemics, but never one that has lasted this long with the advances of medical advances. And that's just because the virus is outpacing its mutation, it's outpacing the behavioral modifications that we've done. And I'll go a little bit into that. But that's the basis for pandemics. So today we'll be talking about COVID-19, which stands for Coronavirus Disease 2019. We call it SARS-CoV-2, that's the name of the virus, which stands for SARS Acute Respiratory Syndrome. And if that sounds familiar, it's because we've dealt with a previous SARS infection in 2004. So, China was hit very, very hard with a previous coronavirus, and that was the original SARS. It wiped out, it had a 10% mortality, and that's what we feared. So this is the same type of virus, same type of aggressiveness, but this one was able to actually get out and reach throughout the country and throughout the world. For us, it's a single-stranded RNA virus, and the reason why that's important is because, here we go again, we have an RNA that's challenging eukaryotes. So what does that mean? So SARS is able to infect us and then go through clinical symptoms that we're all used to by this point: shortness of breath, fever, and respiratory arrest. And the way that it's able to do that, this is a really busy slide, but the only thing that I want to delineate here is that there's different stages of infection. There's early infection, which is what the virus uses to actually replicate. And then you get the pulmonary phase where the virus actually gets to the lungs, and that's what's causing the shortness of breath. And then you get the hyperinflammation. So this is the body's response against that virus's infection, which is what causes most of our problems. So it's a double-edged sword. We rely on our immune system to protect us, but it can also overdo it when when an infection takes over up into a point that by the time the immune system notices that we're infected, it overreacts. So that's where you get the acute respiratory distress syndrome, which ultimately leads to systemic inflammatory response, or SIDS, shock, cardiac failure, and ultimately death. So when this hit us, we couldn't delineate this. So we're at a stage in the pandemic where we can actually delineate how this actually works, which means we can respond to it at different stages, which is good for therapeutics. So it's able to, again, busy slide, but it's able to infect not just the lungs. We quickly found out that it's able to infect the liver, the kidney, intestines, eyes, nose, heart, and blood vessels. And the most concerning as of late is the brain. We're starting to see chronic conditions that are lasting beyond the viral infection. So as you clear the virus, you can still suffer from chronic pathologies that last after that virus has done its damage. And I'll go a little bit into what that condition is called. So these are all numbers, like I said, that were pulled yesterday. So all of this data will be current. So this is the global cases. So we've had about 222 million cases worldwide, but we always underestimate how many cases we have because not everyone gets tested. Not every country has the ability to actually go and get tested and get sequenced. What is good, a good number to take a look at, is the actual vaccine doses administered, because most countries are starting to come aboard and are able to administer those administer those vaccinations to prevent infection. So that's a good number to actually take a look at our population. And then the death, and that's what we use to calculate the death rate. So when we flip that over and we take a look at vaccination efforts, we can see that it's the same countries that have been impacted the most. So when we take a look at the actual numbers in the United States, we've gone through 4 waves. So we started dealing with this early in 2020, and we have since gone through 1, 2, 3, and the 4th wave. And the 4th wave was these last couple months. So starting from July all the way till now, we just started to plateau and started to go down. Daily cases, each bar graph is a daily case. We're starting to crack well over 150,000 daily cases, which is a problem. Anytime that you get beyond the 100,000 cases, we start getting into a situation where the infection rate, the community transmission is quite high. So that means that for every individual infected, you can infect others around you. So we're currently dealing with our 4th wave, and that's where the public health departments are right now. It's not just the cases now. We're also to keep track of emergency department visits. So this is the graph showing you how emergency department visits have actually increased. So as the cases have gone up, where at the beginning of the pandemic, we mostly were contending with asymptomatic cases, and we were seeing high mortality in older age groups. Now we're seeing high transmission, high infectiousness, and hospitalization. So this is emergency department data, and we're in the summer, so these numbers go up naturally as people become more active. But when you cross-reference them with hospitalization data, you see that both graphs actually look quite similar. So these people that make it to the emergency department, they get admitted to the hospital with severe complications of COVID. So we're starting to see a highly aggressive virus. We're starting to see a highly transmissible virus, which is why, though the disease may be the same, we're dealing with a variant that's a lot more aggressive. So the science sticks the same, the virus has changed a little bit. That's how I like to say it. So when we take a closer look at what these numbers look like, when we started vaccinating, we targeted the older age group, so 70 and plus, and that's because they were impacted the heaviest. And then these younger age groups were less of a concern, so we started our vaccination efforts at the oldest, and then we moved down the age groups. However, as this virus has started to mutate and become the Delta variant, which is what we're dealing with right now, it's changing the way it operates. So while sexes have stayed the same, it affects both males and females equally. Age groups are changing. So at the beginning of the pandemic, we had 75 years and older, which were impacted. But if you follow that line, until now, you actually see that is the least the populations that are least of importance for right now for response. Right now, most concerning, what we're seeing are the younger age groups. So that's 16, 17, 12 to 15. So this virus is moving down the demographics and affecting children. This is a function of 2 things. The virus is becoming quite good at attaching to the ACE receptor. And it's also preying on unvaccinated populations. So while we see a good amount of breakthrough infections despite vaccinations, it is preying on those most vulnerable. So those that haven't had an opportunity to actually get vaccinated because they're not eligible yet. So that's important to keep in mind, especially with schools starting. Now in the fall, we're bound to see outbreaks. Same thing with race and ethnicity. It disproportionately affects those minorities. So American Indians, we're starting to see large Hispanic during the holidays, large Hispanic impacts. But right now, American Indians are usually the ones that get impacted the heaviest. These are the numbers for Connecticut. So all of those were national numbers, but all those graphs, if you take a look at Connecticut's numbers, it mimics it. So I like to show national just to show the biggest the biggest trends. So we've had a total of about 380,000 infections. Currently, we have 363 people hospitalized. We're getting into a point where we're starting to increase. These are by week, so 1,600 people every week that we get in addition. The most concerning is the hospital data. So these are ICU, so intensive care unit, and emergency department visits. So if we take a look at how full these beds are, we start seeing that, pediatric ICUs are up to 96% capacity. And that's a problem because we only have very, very few beds, which means that when we run out of beds, hospitals have one of 2 things to do. They can start canceling elective procedures to expand their capacity and use those beds. Or they start actually transferring. So you go to a hospital, they don't have capacity for you, so they transfer you to another hospital. And that's dangerous because that's when people start dying, when you look for a service and you can't get to it immediately. So these are numbers that we look at closely, especially seeing that pediatric numbers are starting to bump up, which wasn't the case. So usually it was the adult ICUs, the adult EDs that bumped up. And this is the trend line. You can see that the hospitals are starting to play with these numbers as they go up to 87, 88% full. They go ahead and expand their capacity to increase the amount of beds and reduce the percentage. So we take a look at that data. I alluded to breakthrough infection, and I use that term very, very loosely. It doesn't mean that the vaccine is ineffective. It just means that the virus is covered at less of a percentage. So while the vaccine was intended to hit the Wuhan strain, which was the strain that we designed it to do, that's that 95% coverage. Here, we're looking at 60 to 70% coverage for the Delta variant, which means that you can have more infection. So for our numbers, we have about 30% of our cases are fully vaccinated individuals that are still coming down with infection and still going to the hospital. About 70% of individuals are not fully vaccinated, which means we need to focus on vaccinating those unvaccinated yet. So these are the number of deaths. It's just a normal bell curve, but we're starting to see again the 20 to 29 bump up. So we'll keep an eye on that for total number of cases by age group. This is what our map looks like. So it's usually red. And that means that there's 15 cases or more per 100,000. So those are per capita numbers. So what we do in Connecticut that most states don't do is that we do a 14-day average. So that means that we take all of the cases for 14 days, divide it by 14, and then we divide it by each town's population, and we multiply by 100,000. That gives us a number that we can actually work with to base this color-coded map. So for the towns that are in red, these are the recommendations that the state has done. So cancel public events and limit community gathering, limit trips outside the home, avoid gatherings. Towns are starting to issue public health alerts, such as mask mandates in certain towns like Rocky Hill and Wethersfield, and collaboration with the health department. So superintendents, now that the schools have started, local authorities have actually reached out to the health department, and we're starting to just plan out how we handle this now that we're back in red. These are cumulative cases by town, and the only reason why I include this is you see the dark blue going up here. That usually shows you how this virus is spreading. That is I-95. It's travel that spreads this disease, right? It's globalization. It only took one case from Wuhan to break it all over the world, and that's because people get on planes. We're not restricted anymore. It's not the 1918s like the Spanish flu where it was localized. No, we have a quickly moving virus, and because people are moving, infection rate follows. So it's good telling. So emergent variants. So I've talked a little bit about the Delta variant. So what does that actually mean? So I'm sure you've heard these numbers or designations in the news: alpha, beta, gamma, delta. What does all that mean? Those are just names for the different variants that we've seen. The B117 came from the UK. That was alpha. Then we had a South African, a Brazilian, and now the Delta variant, which originated in India. Or it was found in India. It could have originated in other countries, but it was sequenced there. So why that's important is that the original Wuhan strain was 2.4. So this is R naught values. This is the replication number. This means that at a 2.4, for every one individual that's infected, you could infect 2 individuals. For 3, it's the same thing. One individual can infect up to 3, 4 to 5, etc. So we're at the Delta variant, which means it has an R naught of 5 to 8. So for every one individual that's sick, you can infect up to 5 to 8, which is why you see transmission increasing. It's highly aggressive. It replicates a lot faster, and it takes less of that virus to actually take hold of the individual, which is a problem when you compare it to the most infectious diseases that we have, like mumps and measles, right? So we administer the MMR vaccine to all children. That's measles, mumps, and rubella. And the reason why we do it is to protect it against these highly transmissible diseases that have R naughts of 18 to 12. That's a lot. So we don't want the mutation rate to continue to get up to these guys. So this is what it looks like. Back in June, the Delta variant only accounted for 10% of infection. As we've moved through these months, it now accounts for 99%. So that's in the US and also in Connecticut. So this is Connecticut numbers. These are Yale numbers. So if you take a look at the Delta variant, 99.6. So it is all Delta out there. So just to show you how aggressive this virus is mutating, a quick change can actually become the predominant strain. So it's outcompeting other strains. So it's outcompeting alpha, beta, gamma, and it's becoming the predominant player. And that's because it's highly transmissible and highly infectious. So it becomes, the dominant species. Busy slide again, but it's kind of like trees on a tree branch. We can track the infection, and that's what we're keeping track of. As this virus changes, we keep track of how it actually moves, and we're able to plot it, on a temporal scale. So we're able to see how these strands actually move throughout our population. So right now, the Delta variant is the biggest concern. And the reason why this is important is that the federal government has started to break apart these variants into 3 different categories. Variant of interest, which means we need more data. Variant of concern, which means that we see what those mutations are conferring. And then variant of high consequence. And luckily, there are no variants in this category, because this means that if a virus moves into this category, it broke through our vaccine. It's poking holes at all our therapeutics, and we have a big problem. So right now, variant of concern, which is the Delta variant, the reason why we're concerned is these 2. So increased transmissibility, I've already shown you why that's a problem, but these 2 are the ones that are concerning. They're able to reduce the neutralization by monoclonal antibody treatments and post-vaccination sera. And what that means is the antibodies that we defend ourselves with when we see an infection, it's able to shake off those defenses. And that becomes a problem, which is why you're seeing breakthrough infection. You may be protected against the Delta variant or the coronavirus, but this virus has gained the ability to shake off those defenses. So this is just the World Health Organization's strands, alpha, beta, gamma, the same ones that we've looked at. But this past 2 weeks, they've added a couple more designations around the world. And Mu is in Colombia. It currently accounts for 46% of that country's infection. IOTA, we're starting to keep track of countries, because all it takes is one highly infectious individual to move, to get on a plane, get into another country, and then introduce a brand new variant to take over, basically. So we keep an eye on that. So let's quickly touch on emergency use authorizations and approvals, because now we're at the vaccination stages. So the time to develop a vaccine has varied as medical advances have increased, right? So typhoid, it took 105 years to develop a vaccine for that. Come to measles, it took 10 years, which was the fastest in 1953. But jump 50, more than 50 years, about 70 years later, it only took us 11 months to develop this vaccine. And I know that worries people and it scares them, because it believes that we went too fast. But remember that you didn't have a personal computer in 1953. You didn't have an iPhone. So our technological advances have gotten us to the point where we can actually develop these technologies that make us go pretty quickly. So how do we do it? So clinical phases were not skipped. No corners were cut. I know people were concerned about that at first under an emergency use authorization, which means that you're able to use it, but it's not approved yet. And I know that that scares some people, but that's just the normal process. Emergency use authorization, when there is no alternative, that becomes the standard of care until all these clinical trials finish. So we were able to go ahead and stagger these clinical trials, which means that we weren't able to start one, finish one, and then start the other one and finish one. You can see how that stretches out the timeline for development. Because of medical advances, we were able to stagger them and run all clinical trials in different populations in a staggered fashion as soon as we cleared safety guidelines. So yes, we know that there's no side effects. Yes, we know that people aren't dying from this, and we're able to move through. So right now, the ones to be determined are pediatrics, pregnant women, and immunocompromised populations, and we're seeing expansions into those age groups already. So, we started with healthcare personnel and those in long-term care facilities back in January. Then we moved on to frontline essential workers and those age 75. And now we're at a stage where all people age 16 years or older are eligible. And for Pfizer, it's 12 years and over, because they received an expansion in their EUA. So in December 11, 2020, that's when the FDA approved Pfizer, which was the first EUA. It was followed by Moderna just a week later in December 18. Then it was followed in February 27 for Johnson & Johnson. So in America, we have 3 current vaccines that are active under emergency use authorization. In May, Pfizer received an expansion, and that means that previously we were able to vaccinate those 18 years and older, and now Pfizer can be used for those individuals age 12 and older. So we're starting to expand into the younger age groups, and both of them went ahead with all that data and sought FDA approval in May and in June, respectively. Thankfully, a couple months later, Pfizer has finally received FDA approval in August 23rd, 2021. So just a couple weeks ago. So that means it's FDA approved. And the reason why I bring up Jacobson versus Massachusetts is that this is a precedent-setting case back in 1905. Jacobson was a pastor in the state of Massachusetts who said that the state doesn't have the authority to force me to get vaccinated. And this state went all the way up to the Supreme Court. And what it said was that the state's absolute liberty is basically limited, and it is subject to the policing power of the state. So the only reason why I bring that up is that a lot of people were waiting for FDA approval to get vaccinated, but so were employers. So for those that are hesitant, employers can now require that. And that's what you're seeing in hospitals, in schools, and they're legally able to require you to get vaccinated now. So just, if you're hesitant about getting a vaccine, that's always to keep it in the back of your mind. Just data and also what the state has the power to do. So vaccination. So I'll quickly go over this. These are our vaccinations. We were very, very good once we started expanding, but as of now, we've plateaued, and that has become an issue. That's why Connecticut's about 60% vaccinated. And we're struggling. We're starting to just plateau out, and vaccination rates are starting to decrease. They're slightly bumping up now that school's in session. So we'll keep an eye on that. But as of now, in the state of Connecticut, these are the age groups and the percentage vaccinated. So 75 and older, we're almost vaccinated at 85%. 65 to 74, they're doing amazing, 90% vaccinated. But the ones that we have to catch up are the kids. So 12 to 15, it's 53%. So that's fully vaccinated. If we take a look at the initiated vaccinated, that means that they've gotten one of these. These numbers will convert into fully vaccinated 2 weeks from now. So, they gotten their first dose, they're waiting for their second dose. So our numbers look good. This is a map that I won't go into. I will share the link so you can take a look at it, but it basically shows you the cases per 100,000 and the percentage of the population vaccinated. And you can imagine that this box is bad because that means that there's the highest case rate with the highest vaccination. So we're starting to see the country fill up with that. And that just tells us that we're having breakthrough infections. And we want to be here, highest vaccinated with the least amount of cases. So whether the federal government decides that boosters are what gets us to that stage, or a strain change on formulation change on the mRNA, that's what we're moving next. So the next thing that I'd like to do is just a very simplistic way of how we actually target this virus. So on the left-hand side, we have the coronavirus. And on the right-hand side, we have an electron micrograph of the actual virus inside a tissue, so inside a cell. So if I overlay a diagram over it, what you see is the nucleic acid, right, the RNA genome, the actual envelope. And what I bring your attention to are these little things right here, which is where coronavirus, which is Spanish for crown, it gives it its name. It looks like spokes on a crown. These are called spike proteins. And the reason why that's important is because that's what we use to vaccinate against. The virus uses its spike protein as a key. So when you come down to a cell, we have many receptors, but the receptor that this virus exploits is the ACE receptor. And that's the angiotensin converting enzyme receptor, which just means that we use that receptor for hormonal communications for our lungs, heart, kidneys. That's how our body regulates itself. So the spike protein is being able to use as a key to actually get inside the cell. So it's able to attach to that receptor and gain entry into the cell. And that's how this virus infects cells, by using its spike protein to take advantage of the ACE receptor that's already there. So if we know how the virus works, how does the body defend itself? So let's say that we're able to go ahead and throw up a shield, and that shield is able to block that key from ever even reaching the cell. It means that we maintain our immune system is able to protect us from infection. And what we call that shield is an antibody. And that's what the body does to protect itself. And that's what vaccine does to basically protect the individuals that are vaccinated. That's quite simplistic. This is what the diagram actually looks like. There's many players, from antigen presenting cells like macrophages and dendrites to beta cells, T cells, plasma cells. But basically what we want are these Y-looking proteins, which are the antibodies. The reason why we want to do this is natural immunity. This graph is a little bit, this is standard, and this is when we get into problem. The only thing that I'd like for you guys to see is that as the viral load increases, the immune system can't keep up. And that's how severe COVID infections go. What we'd like to do is get back to here. So as the viral load increases, our bodies are able to respond. So, and the only way that we do that is by priming the body, and that's what vaccinations do. So we have multiple methods of vaccination, from the traditional flu vaccine that's an attenuated virus, to viral vectors, which is the Johnson & Johnson, nucleic acid vaccines such as the Pfizer and Moderna, and then protein-based vaccines like Novavax. So different technologies that are at disposal. We have vaccines that are already developed in each of those categories, from flu to SARS to West Nile to Zika to chikungunya. So we were able to go ahead and select from the technologies that we have, right, that are different than the attenuated vaccine. So we have advances in medical knowledge to develop the vaccines that we have now. So what we ended up having is we have Pfizer and Moderna, which are both mRNAs, AstraZeneca, which is in the UK and most of the world, Johnson & Johnson, which are both adenovirus vector vaccines. And then these guys, which are coming up quite quickly. Novavax is showing the most promising results. So that's a protein-based vaccine. So how do they work? So I showed you that simplistic diagram. So this is how it actually works in the body. So when you get injected with an mRNA vaccine, it gives you that little piece of mRNA. Again, we're eukaryotic, so it doesn't touch our nucleus, which means it can't impact our DNA. I know a lot of people are afraid of that. It stays in our cytoplasm, which is why the prokaryote versus eukaryotic difference is important. That allows our body to make these artificial keys. These keys look very, very similar to the coronavirus's spike protein. And it's creating those keys. So when the cell exports it out into our bloodstream, our immune system is able to respond to them, create those antibodies against them, and then the keys go away because these proteins are unstable. So you get vaccinated, you make it, the immune system responds, and those spike proteins degrade, right? They're artificial. They're not attached to an organism. But what does remain behind are the antibodies, which is the next time that you get infected, that's what defends you. So adenovirus vaccines is the same way. The only thing is that you're getting a viral vector, which just means a virus that's been genetically engineered to have that same mRNA protein or mRNA nucleic acid that gets exported. Same keys are developed. And this is how Johnson & Johnson works. The last slide was how Moderna and Pfizer work. So again, the antibodies are created, and that's what remains behind after the artificial spike proteins are gone. So the way that we gain immunity is the next time that an individual breathes that has been vaccinated and the coronavirus gets into the lungs and they become infected, what they start getting is all these virions. So again, these virions, I've replaced all the spike proteins with the keys, but what's lasting in the bloodstream is those shields, those antibodies. So the next time that the coronavirus tries to infect them, they're blocked. And all of those shields coming together, that's how we actually confer SARS-CoV immunity. And that's what this vaccine is meant to do in a simplistic way. So, so next I'll move on to pathology. Does anybody have any questions before I move on to clinical slides? All right. Sorry, guys. I see Teresa has a question. Go ahead, Teresa.
Hi, thank you. I'm in Rocky Hill, and glad to join you. Very informative slides. You mentioned earlier about the, what's the word? What was it?
Yep, the R naught, the reproductive number.
R naught, yes, yes. How is that calculated or determined? Because if an infected person is around, like it said, 5 to 8 people, you know, what if it's 20 people? that same person is around, does the R naught go up higher, or is it just that 5 to 8 people susceptible?
So the R naught is there's a lot of calculations that go into the reproductive number. So the diagram that I showed you was its impact, but not how it's calculated. The way that it's calculated is how quickly does a virus replicate. So one virion gets into your cell and then it makes copies of itself. That's what it's designed to do. We take into account how fast the virus is able to do that, and then how much of a viral load, right? What is the volume of the virus that it takes to infect an individual? So using those numbers, we're able to determine what's the reproductive number, which is the R naught. So it's less population based. It's more of how quickly a virus replicates and how much of the virus is needed to actually infect an individual.
Okay.
So I'll show you a little bit about how this virus looks inside a lung. So this is a cell, a regular cell, and this is a cell that's been infected. So you can see that it actually pokes a lot of holes into our cells. So these are variants that are actually replicating in these little pockets. And our body protects itself. It's kind of busy, but these are the two things that I like to point out. There's a call for reinforcements, which tells the body, I need help. I'm getting infected. Call the white blood cells, the immune system. And then there's a call to arms. And that tells every neighboring cell, hey, I'm getting infected. Prepare for war, basically. We have a virus. The coronavirus blocks the call to arms. So a cell that's getting infected can't notify its neighbors that it's getting infected. And what that does is that it allows the immune system to come in still, but by the time it gets there, this isn't checked. This call to arms checks localized infections. It's able to keep it at bay while the immune system responds. By the time the white blood cells respond to it, the infection is rampant in an organ system. And this is what it looks like. It's able to go ahead. This is a lung tissue, the histological graphs. So a virus is able to get into a small alveoli, and actually, this is necrotic tissue, dying tissue, able to kill off large portions of the actual lung. The problem is that by the time the white blood cells get there, and it's no longer a localized infection, the white blood cells overreact. So all of this pink stuff is fluid, and that is inflammation. And when all that fluid comes up, you could see that all this white space is air. So this is our alveoli. If you could imagine, I just cut it down. I just took a lung and just cut it into thin sheets. You can see all the air pockets that allow us to breathe. All this fluid in there, all these blue things are white blood cells. That doesn't allow us to get much air in. And that's how people go into severe acute respiratory distress. And that's how people are able to pass, because they can't get air in there. Their oxygen saturation rates go down, and all that fluid leave them susceptible to pneumonias. When you have a lot of fluid in your lungs, you get pneumonias, and you are susceptible. You start with a viral infection, and then you could get a super infection with bacteria. So that's the problem. So you can see it's a double-edged sword. We're trying to protect ourselves, but the virus is using our defenses against us. It's very, very ingenious the way that it operates. So the reason why I bring that is that that's determined. So we know what the pathology is acutely. So that's just for the 10 days that you're infected. The thing that I like to point out is post-acute sequelae of COVID-19. And that is the chronic condition that we're starting to see of people who get infected with this virus, clear the virus, but still remain sick. So the virus is able to go into the nose. It's able to go down into the lungs, but we're starting to see that the virus is actually able to get into the brain as well. And it does this through our olfactory bulbs. This is a cranial nerve, it's called. It's an extension of our brain that allows us to breathe and smell and taste. The virus is able to use that to get into the brain. The problem with that is that when it uses the olfactory bulb, it goes into the limbic system. And what this limbic system, this part of the brain control, is memory and emotion. So when you get a viral infection on those, what you get is COVID brain. Some people complain about long haulers, COVID long haulers. Their emotions are off. They go into depression. They go into anxiety, aggression. Some people are just very, very tired. They can't remember the things that they used to. And that's what we're starting to see impacts, some cerebral impacts just from limbic system infection. What we're also starting to see is that the virus is able to go ahead and infect the white matter. So busy slide, but all that means is that this can get inflamed. The gray matter is where all the cells are. The white matter is where all these long strands are. So that's how the nerve cell communicates. It's white because it's very fatty. So oligodendrocytes and Schwann cells, they insulate the nerve cell kind of like a wire. You're able to coat the wire and it's able to move the conduction a lot faster. When you get inflammation at these, it disrupts communication, and that's when you start seeing different neurological symptoms, slowed receptors, things like that. So the things that we end up with is these types of conditions. Para-infections manifestations means that conditions that develop while the individual is infected. So the anosmia, that's the lack of smell. The encephalopathy is an inflammation of the brain. Stroke, we are all familiar with. Meningitis, seizures. Leukoencephalopathy, which just means inflammation of the white matter. And then Undine's curse. Undine's curse is a German fairy tale. I'll go into it briefly. It's a German fairy tale where an individual falls in love with a nymph, but he's unfaithful. And the nymph casts a curse on him that should he fall asleep, he'll suffocate because he won't be able to breathe. So the individual can never get any rest because if he sleeps, he dies. We use that German fairy tale to call that for this like very, very freaky disease that we're starting to see, where an individual loses its receptors, its carbon dioxide receptors, when they go to sleep. So they basically suffocate, and that is a cerebral concern. So this is very minimal, but we're starting to see that crop up, which is a bit scary, obviously. But I don't want to alarm anything. This is the unicorn in the room. We look for horses, maybe some zebras. We stay away from unicorns because they're very rare. So the post-viral symptoms are more the ones that we're looking at. So myalgia, stuff like that. And what we get is some sort of autoimmune disorders that are starting to stay with individuals. I won't go into any of them, but just so you guys know that after the infection is cleared, the immune system actually starts targeting self. So it forgets kind of like what we look like, and it starts overreacting against self. And what you get is an expansion of symptoms. So while we started at the beginning of this with fever, cough, and shortness of breath, the symptoms that we're seeing now are quite extensive. So they range anywhere from muscle fatigue to neurological defects to diarrhea to fevers and chills. So when we take all of these conditions and we lump them by organ system, what we see is that the brain is impacted quite heavily. Then the body, the lungs not so much, but joints, head, muscles. So we're starting to see what all these symptoms actually mean, and that points us to what damage is actually being done, damage of which that lasts long after the virus is gone. So when we go ahead and we plot and it's hard to read, but I just want you to see the shape of it. When you plot all of these symptoms in a year's worth, you start to see that these symptoms actually have a wave-like pattern. So an individual may be suffering from these symptoms at the beginning, and throughout the course of the year, they'll start developing more and more different symptoms with different organ systems. And that is the telltale sign of a chronic disease. You may go to a doctor, and the first question they may ask you going forth is, have you ever had COVID? Because that may be a starting point of actually doing some diagnostic testing. So, the media is starting to catch on. They're saying mysterious ailment, mysterious relief. But the good part is that vaccines are starting to help these people. So these people who suffer from long haulers COVID syndrome are actually able to recover with vaccinations, because what we're seeing is that vaccinations are able to recalibrate the immune system to stop targeting self and tell it, no, this is what you're looking for. Stop attacking yourself, attack the virus. So good news, another push for vaccinations. So that was it. And then this is the last part of the slide. I will play this video very, very quickly. This is social restrictions. So I want to show you what masking is. I turn off the volume. So this is a loosely fitting mask. You can see that as a person breathes, it pushes the air backwards. So you can see that, a room that has no ventilation, it quickly can fill up with viral particles. Now, when you switch that mask and you put on an N95 or a well-fitted mask, you actually see that it's very minimal of how the air actually moves. So well-fitted masks are the way to actually get through this, to actually keep your people's germs to themselves, in addition to social restrictions. So a good way to actually see the changes of this outside of coronavirus is influenza. It's flu season, so we're all ready for the flu. So in 2019 to 2020, this is what the US map actually looks like. This is week 6, so this is during the heart of the influenza season. Peak is January, February. So you can see that most of the country is around high to very high activity level. Most people are coming down with the flu. So if I go forward just 1 year, so that was last year, 20 to 21, during the same period, week 6, we're at minimal transmission. And the reason why is because people stopped moving, people were wearing masks, people were washing their hands, and you can see that social restrictions and masking actually works when you see it with other conditions. So influenza, foodborne illness, all these things. So as we go ahead and try to get back to normal life and social restrictions are lifted, vaccinations become that much important because we know a lot. We lose the masking, we lose the social restrictions, which means we really need to protect ourselves through therapeutics. So just be aware that co-infection and synergy is possible. We're dealing with 2 respiratory viruses that can both affect the lung at the same time. Both of them cause similar symptoms. Both of them can cause pneumonias. And when you get 2 viruses causing pneumonias and a superinfection for bacteria, we're waiting for a perfect storm. So going into the fall, a cheap plug for the Central Connecticut Health District, we're hosting drive-through flu clinics the month of October. So, postcards have gone out if you visited our health district before. Flyers and press releases have gone out. These are our dates. So we have 2 clinics in every town, one in the morning and one in the evening. So 2 to 6 and 10 to 2. And then we have 1 additional clinic for families on a Saturday in the morning. So if you go to our website, you'll be able to visit our vaccination portal. Vaccination is by appointment only. So if you visited our clinics, for changing it this year, you need to schedule it. You can't just drive up. So, pick a tile, pick your town. Once you're there, you're able to go ahead and click on the date that you want. You'll fill out a quick intake form, and then you'll get a text message and an email with your confirmation. And then you'll just show up and drive up at your scheduled time. So that is our plug. That is it. So I welcome any questions you guys may have.
Louis, I have a question.
Mm-hmm.
So I know the answer, but I wanted to let others know. So if you couldn't make the clinic for the flu vaccine on your town, you can go to another town?
Mm-hmm. Yep. So we're open to all of Connecticut. We're not limiting to our district residents. So most of our programs, because of grant restrictions, we're able to do that. But flu clinics, that is a district funded initiative. So anybody can come from the state of Connecticut.
Thank you.
Maddie?
Hi. You know what? Wow, this is really scaring me, this whole thing. I'll tell you what. What is the way that we're going to be able to get cured of COVID? I mean, we're doing all the right things. People are getting vaccinated, social distancing, wearing masks. And I mean, do you ever see this ever going away?
Mm-hmm. Yeah. So what we're seeing is that at the moment, the reason why it looks so scary, and I'm sorry if I alarm anyone. This is just an up-to-date briefing, so a lot is happening at once. So it's a lot to take in. It's like, drinking through a fire hose. But there's a lot of good work happening behind the scenes. So what we're starting to notice is that the virus is mutating a lot faster than we're changing human behavior. So there's talks about changing the vaccine that we have. Like I told you, it was designed for the Wuhan strain. But because it's mRNA, we're able to change that sequence and tailor it toward the Delta variant or all of the variants that we have our eye on. So technically, when we get booster shots, which is what the HHS recommendation is, it's being contended, but 8 months after you get your second dose, you should get vaccinated again. We have an ability to tailor those vaccinations to protect against the one that we're contending with at the moment. And then we're pushing a lot of efforts to vaccinate those young individuals. So in between expansions, it looks like we're going to move to ages 8 and older. And then in next year, we'll move on to 6 months and older. So when we get full population coverage is when we actually start fighting back and getting a hold on this virus's mutation. So.
Okay, and I have another question. What do you, where do you get these M195 masks? I mean, all the stores that I have gone to, we don't have them. And, like if you go to Walgreens or to CVS or ShopRite or something like that, I don't see them being sold. Where would you actually purchase those masks?
So personally, I just use Amazon. As the district, sometimes we get allocations, but we've been able to secure our masks through distributors. You see N95 masks going into, a lot of times you see like fairs, they're giving out surgical masks, but the supply is starting to recover, which is what the issue that you're seeing, that stores are getting depleted. Manufacturers are able to recover, so we're starting to get a lot more N95 masks and all the masks that you're looking for. So online suppliers should have them, and soon the stores should have them. I mean, toilet paper's back, so that's good. Good.
And one last thing. How can you explain somebody that really got COVID-19, but they had no symptoms and they didn't feel sick? And how can you explain that?
So it's the way that some viruses work. So there's a difference between a carrier and an individual who's actually infected. So the way that viruses work is that an individual is able to harbor an infection, but not necessarily suffer from it. We call that, when it's a species, it's called the reservoir. So if you think back of the Black Plague, rats were able to carry the infection, but they didn't die, but they were able to pass it to humans. Every species has that ability. So for people who get infected with coronavirus, they don't necessarily show symptoms. And that's called an asymptomatic transmission. That means that the person who's sick doesn't know that they're sick. So obviously they're not trying to harm anyone, but they're still carrying that infection forward. This virus is changing to the point that that's less of a concern, and more of a concern is that symptomatic infection. And that's just because the virus is able to get a little bit better to attach to that ACE receptor. But that's it. That's just a normal trend for most infections. You get a lot of people who are asymptomatically transferring the disease.
Okay, thank you very much for answering my questions.
No problem.
I have one more question.
Good.
How do you communicate to businesses in the Central Connecticut Health District, specifically stores? Last year when I went into stores, most people were following the protocols, wearing masks, socially distanced, following the arrows on the floors and everything. So mostly respectable. Now I go into stores, including this morning, and people just barge right into the doors without masks. They don't stay socially distanced until you kind of have to turn around and look at them and say, excuse me, can you step back a little? I don't understand, why the stores they even took down the signs that said masks are required. I live in an apartment building where they took the signs down out of the elevators. So people now barge all into the elevators without masks. So, as the health district leaders, is there a way to communicate to the businesses that they need to get a little tougher?
Mm-hmm. So, and it's a good point that you bring up. What you're starting to see is that, you have to have legal authority, which is why I went through that slide of what grants us legal authority. Mm-hmm. So the federal government has legal authority, and they've lifted, restrictions. The federal government is able to make restrictions, and the state is able to be more restrictive, but not less. So as the federal government becomes less restrictive, the states become less and less restrictive. So what you're seeing is that the executive orders that our governor, the Governor Lamont has initiated are expiring. Mm-hmm. So the last declaration of emergency expires on September 30th. So when that goes away, the state has less power as a legislative body, and it moves down to the local governments. So it becomes quite taxing for local municipalities to enforce that, because there's no teeth behind it. So what you see is that there are less mandates and there are more recommendations. And that's because though we can find somebody, it's hard to actually enforce it to a large scale population. So that's what you're seeing, just an expiration of these restrictions.
Oh, that's really sad, because, the kids are going to be the the ones who suffer the most now and in the future until all the kids can get vaccinated. It's really sad. I mean, I saw a school bus that pleased me the other day. School bus was filled with kids with masks. They seem to be very comfortable wearing masks. But when the bus stopped to let the kids off and the parents met them, none of the parents had on masks.
Yeah.
So,
yeah. I mean, the only comfort I can offer you is that, at least for our agency, we have a good team. So when these numbers started going up in July and in August, we hit the red button and we called an emergency meeting. So we met with the town mayors, with the town managers, who are the CEOs for the towns. We met with the school superintendents, and we advised them on protocols and what to follow. And we're in constant communication because this is such a quickly changing disease that they need to maintain up to date. So these briefings, I do it all the time, and I do it to people whose decisions actually matter. So our mayors issued mask mandates for Rocky Hill and Wethersfield. We're still working on Berlin, and we're still working on Newington, but it becomes quite political. So, elections are coming up, gubernatorial elections and mayoral elections. So that's where you're starting to see that public health measures are starting to be muddied. But you can rest assured that Central Connecticut Health District tries to push public health is at our focus, and that's what we do. We just recommend, and we recommend hard by showing, up-to-date data all the time like this. So.
Yeah. Well, thank you.
Thank you, Louis. I just had a couple of things to say. I was amazed at that map with the flu. I mean, that's crazy, the difference that masks made last year. And hopefully, I mean, I just think about previous years at the library, how a staff member would be sick, and then we share phones and everything, and then everybody's sick, and that didn't happen last year. That's just amazing. But I do have a question about India. You said that the Delta variant began in India, or the outbreak really started there. Is India doing better? So is there hope for us in that way? Did we see that India improved?
India has a different set, because it's a lot of regions in India are considered third world countries. Their vaccination rates are far behind what the rest of the world. So they struggle. And though it was sequenced there, their testing and their sequencing are very, very low. So we get a glimpse of what's going on there, but it's not accurate because it's random sampling. Yeah. So, they're struggling just like Japan is, just like the UK are. It's just those countries are willing to impose restrictions. So the UK has gone back into lockdown. Australia went back to lockdown. New Zealand had one case and they shut it down. The US is less likely to do that because of the economic impacts and because of the backlash. So, each state has to figure out a way to actually keep safe without locking down the entire country. So,
yeah. Okay, so we really can't compare it to India because of a different situation there anyway. Yeah. So it's not accurate, probably information. Okay. My last question is the 1918 flu ended, and then you actually brought up a very interesting point about that people weren't traveling as much then. So, but how did it finally end?
The Spanish flu was caused by H1N1. So that sounds familiar because in 2009, we contended with the same virus and it took our populations by storm. The reason why it was so deadly in 1918 is because we didn't have the medical advances that we have today. So people were dying very, very quickly. But we still deal with the same fast-moving virus today. So in 2009, you remember that we had to have vaccinations. I was in college, and my girlfriend at the time, who's currently my wife, had to get vaccinated before me because it was women and children, based on what that virus affected. So it was women and children first, then the rest of the population. And that one was a live vaccine. So it was a weekend. So you had to get that aerosolized thing up your nose. So we've responded to pandemics like this. They're just less covered by the media because we haven't had a virus take our global populations by storm. So influenza tends to be seasonal, where it starts in the southern hemisphere. So we see Australia go through their flu season before us, and then we change our vaccine quickly to tailor to what they saw. So our vaccine, which is quadrivalent, that means it has 4 strands. We tailor it to what we saw. So H1N1, H3N2, and every year we change our flu vaccine, trying to stay ahead of a virus that because we've dealt with it for 100 years, we can predict its mutation. This virus, we haven't gotten to that point yet. It's moving quicker than we can actually predict it, but that's how that ended. It killed itself off. It ended, the season ended, and then it went back down. Yep, and then we responded to it. But yeah, so it'll rear its ugly head back again. It always does.
Well, this has been so informative. Thank you very much for talking to us tonight. As you heard, we did record it. And I know that you mentioned, this data information that you presented tonight is as of today. So yes, we will hopefully be able to share this on our website or maybe our social media, but we will mention that this is as of today. Things constantly are changing with this, but I think we all learned a lot tonight, and hopefully that more people who watch the video will also learn a lot. So thank you very much for taking the time tonight to talk to us.
Well, thank you for giving me the opportunity to do so. And, if anyone has any questions, just to leave it on the slide, here's my contact information. You can reach out to the health district, or you can reach out to one of us. We're pretty receptive. Email, that's the main extension line. One of us will respond. So I encourage you guys to reach out if you have any questions and you're watching this at a later date.